So I'll give a quick introduction. So how many people know Dr. Silver already? Yeah. So let me just kind of reinforce what many of you already know, and for you who don't, Dr. Silver really has I don't know, I think you came here in the 80s. Was that like in the 1900s?
1880.
Yeah. So his work here at MUSC has really allowed for us to have the depth of healthcare that we can get here at MUSC, and research that's been really focused on treatments and ultimately cures. And he has really dedicated a tremendous amount of effort. I can't tell you how many times he comes to all of our things, drives all over the place to meet with us. Susan and I, we do planning. He works with us. And we wouldn't be here if it wasn't for Dr. Silver, because Dr. Silver planted the first idea in Susan's head about having an education conference here. But more than that, really building a presence here in South Carolina to make it lucky for those of us who are able to get here to have care at a higher level than we could possibly if we weren't near a scleroderma center. So thank you, Dr. Silver. And you're going to share the hot topics. Here is your clicker, and I'm going to put it in presentation mode. So we're wrapping it up with this, but I want to also remind you guys, fill out those evaluations. And when we wrap up there, we were going to make you take snacks home because there are a lot of snacks left over.
All right, so I have some good news. I'm not going to talk for an hour. So maybe we'll get out and see the beautiful day. But I always enjoy preparing this talk because it gives me an opportunity to talk about the division of rheumatology here at MUSC and touch on some of the people and what's going on. And so the first part of this presentation, I'll tell you a little bit about the division, and then we'll get into hot topics. And I chose 3 topics that I think are really should be of great interest to people with scleroderma. And certainly there are many more than 3, but time limits. So let's see if I can figure out how to use this mouse. There we go. So a few words about the division. This is or about this program, actually. So this is our Sweet 16. So 16 years ago, we had our first meeting here on campus, and it's now sort of co-sponsored by the Division of Rheumatology here at MUSC, and with some support from the National Scleroderma Foundation, for which we're very grateful. And there are 3 people that really are responsible for this. The first is Amy, shown here back in 2006 with a much younger version of myself. This was what one of our stepping out fundraisers, 5K walks. Probably this was in Greenville at Clemson. You know, Amy was good. It was Susan's best friend. And when Amy was very sick, she told us that she really wanted people to know more about this disease. She wanted patients to have be empowered with knowledge about the disease. And this is a theme that has run through these meetings for the past 16 years. And we heard it again today from you. So it's a wonderful legacy that Amy has left us. And we couldn't do this without Susan and Karen. So big round of applause for them. You know, it's not easy to sustain any sort of program for 15, 16 years, but it gives you some insight into how devoted they are to this cause and what an inspiration Amy was. So, and we did not coordinate our talks at all or our slides. So this is just a random coincidence. So this is what we strive for here at MUSC in the rheumatology division, patient-centered care. And of course, you and your family are at the center of this. And in addition, you may have other family members, your own providers, whether it's a family practice or internist, and maybe a community rheumatologist. You have all of these support people around you. And I guess one of the themes we heard from the last session was it's very hard to get communication. And that's something we certainly need to work on. But I just want to shout out to the support group leaders and people who attend on Saturdays every month. It's a great resource. And if you haven't taken advantage of it, please do, because one thing is you find out, you're not alone. Other people have similar problems, and maybe other people have good ways of getting around those problems. So we can all learn from one another. And then a whole cadre of specialists who over the years here at MUSC have developed an interest and an expertise in scleroderma. So let's talk about, I don't know how to move that up off of there. So this is the division of rheumatology led by Dr. Oates, was led by Dr. Oates. Up here, his head is cut off there. Yeah. Anyway, the division is getting larger. It's hard to even keep up with it, but I think this is fairly current. And there are a number of many, you'll see some of your doctors up here maybe. The ones who primarily see most of our scleroderma patients just happen to be in the middle row here. So there's Dr. Minkin, who was here this morning, Dr. Baker Frost, who gave a great talk, Dr. Schmidt, who is also the program director for the fellowship training program. Dr. Kate Silver, I've already had one complaint about her from somebody here today. So she sees children and adults with scleroderma. Dr. Hand, who's the program director for our rheumatology training program. And what happened to my talk? And Dr. Ward. But all of us all of the clinicians do see patients who have scleroderma. We have expertise here that really I don't think anywhere else, certainly no place else in the state has such expertise. And then on the research side, we have, so let me go back. So I'm there in the middle, and a lot of my friends say, well, how come you're still working? Why don't you retire? And I realized the answer is in this slide. So I work with these very bright, compassionate women who are taking care of our patients. And so why should I retire? But since Harriet's here, she's an expert on Southern literature. So there's a story about Mark Twain, and it's probably not a true story, apocryphal story, but Twain was in London, had been ill, and then he reads the Philadelphia newspaper. He reads his obituary in the paper. And so he wrote a letter back to the editor of the newspaper in Philadelphia and said, reports of my death are greatly exaggerated. So I've paraphrased that. The reports of my retirement are greatly exaggerated. So those are our clinicians for scleroderma. And then on the research side, our leader is Carol Fagali-Bostwick, who, is she still here? No, she left. Anyway, she's a very modest, humble person, but she is an internationally renowned researcher in scleroderma. And we're so fortunate to have her here on our faculty. And one of the great things about Carol is she's a tremendous, not only a very brilliant scientist, but she's a great mentor. And she shares her skills, her teaching, her mentorship with young investigators, not just here at MUSC, but and not just in the United States, but literally all over the world. And then Dr. Renaud, who was here earlier, is one of her proteges. She's now on our faculty, assistant professor of medicine, doing great work. Dr. Bogatkevich, who works in my lab, and Dr. Hoffman. So these three lab groups are each trying to discover and develop new drugs that are anti-fibrotic. So we're at the very beginning of a long pipeline trying to find drugs that will one day be useful for not only for people with scleroderma, but many other fibrosing diseases. And Dr. Betty Sau, whose main work is in genetics, the genetics of autoimmunity. Most of her work is looking at lupus, but there's a lot of similarities, both clinically as well as genetically. So we count her among our scleroderma researchers. And then part of our, what we do in rheumatology here, part of our mission is to train the next generation of clinicians, as shown here, but also the next generation of scientists as well. So our adult fellows are on the top row. Dr. Werner, who was here earlier today, I believe, is finishing up, and she's going to take a faculty position at West Virginia University, where one of our other faculty members, one of our other trainees is also on the faculty. Dr. Donaldson here will finish up. She's joining a very strong private practice group in Asheville, so more expertise on scleroderma in that part of North Carolina. Brandon Liu is finishing up. He's joining three of our former fellows who are in practice in Athens and Gainesville, Georgia. Dr. Smythe is staying on, hopefully staying on the faculty. And our first year fellows are Dr. Hassan and Dr. King, who was here earlier today. So training this next generation is an important part of what we do. And we also have a pediatric fellowship training program in rheumatology. And Maddie, who's shown here, is sort of like my daughter. She can't do just one specialty. She's going to do adult and pediatric rheumatology. And then we have our team. Some of them are back there in the back. This is our scleroderma clinical trials team, and led by Lorianne. Welcome back, Lorianne. We missed you. And then here we have in the Dr. Baker Frost and my favorite coordinator, Miranda. Raise your hand, Miranda. There she is. With one of our patients, Patricia, who is one of our research trial subjects and who gave me permission to show her picture. And also doing clinical trials work is Dr. Hant and myself. And then two people who sort of work behind the scenes, Jackie, and our newest member of our team is Veronica, shown here. Raise your hand, Veronica. Always in the back, but keeping our clinical registry and databases and straight, and keeping the clinicians straight as well. All right, so underneath that banner, which you can't see, there's the top line there says, it takes a village. And again, this comes back to exactly what we were talking about before. So because in large part, because we've been devoted to scleroderma care and research for now 50 years here at MUSC, many patients come here from long distance and locally as well. And so we've developed a very close association with subspecialists. And so, your average pulmonologist can take care of asthma and COPD and lung cancer, things of that sort. But when it comes to interstitial lung disease from scleroderma, they just aren't that familiar with it. So now we have on the pulmonary side, we have Dr. Menon, no, yeah, Dr. Menon and Dr. Krishna, who, I guess I've lost my pointer here. They're specialists in interstitial lung disease. And then on the right, we have Dr. Argula and Dr. Sese, who are specialists in pulmonary vascular disease, so pulmonary hypertension. And these are both very complex complications, and it really requires somebody with a lot of expertise to help manage them. And we work very closely with them on a daily basis. On the cardiology side, we have two cardiologists who actually came here. They both came from Johns Hopkins, which, like MUSC, has had a strong clinical interest in scleroderma for 50 years. So Dr. Tedford on the left and Dr. Houston, they're the ones who take care of getting the right heart catheterizations and the invasive cardio exercise tests when we need them. And we're very grateful for their expertise. In GI, they come and they go. So we lost one of our GI scleroderma specialists this year. But we have Dr. Elias, who's fantastic and probably should be a speaker in the next year, the year after. And Dr. Sharma, who I actually haven't even met yet, he's brand new to MUSC, came from Augusta University, or what used to be Medical College of Georgia, and he's a motility specialist. So he is also somebody we should probably invite for a future session. Some of our patients, either because of calcinosis or severe Raynaud's with digital ulcers, will need a hand surgeon or a plastic surgeon. We have three who have expertise with scleroderma. So we have Dr. Tavana, we have Dr. Daly, and Dr. Daly. And they're not related. They spell their names differently, and I couldn't tell them apart. So I just write Dr. Daly, and but they do some of the digital sympathectomies and some of the plastic surgery that is required. We have great dermatologists who are very familiar with scleroderma. So we have Dr. Winterfield, and more recently, Dr. Hashimi. She was our keynote speaker last year. A great expertise to have for our patients. And then we have a dry eye specialist, Dr. Fernandez, in ophthalmology. And then you heard Dr. Trahan earlier today. We're very blessed to have somebody in oral medicine and dentistry who has a strong interest in scleroderma. And I don't have room on the slide, but we should put pharmacy, physical therapy, occupational therapy, but the good thing about this is we're all on Epic. We all communicate with one another. We see one another at conferences, and so we can coordinate what can be very complicated care. So the National Scleroderma Foundation has now designated certain centers as research and treatment centers. And so if you can demonstrate expertise in the care of individuals with scleroderma, conduct research, whether it's clinical trials or translational or basic research, and then conduct educational activities, you can be designated as a scleroderma research and treatment center. And over the years, the number of centers achieving this designation is increasing. However, I still think we're the creme de la creme when it comes to being the most robust in every one of these facets of scleroderma care and research. All right, so enough about us. So these are the hot topics. Artificial intelligence, new drugs, and cellular therapy. Okay, so I'm learning about artificial intelligence, AI. I think it should probably be called augmented intelligence. But and some of our much younger people like Dr. Farrell and Dr. Trahan are very facile with it, but even they tell me that it's changing so fast they can't keep up with it. It's absolutely mind-boggling what AI is doing. And on the education side, our students are using it. It's not AI will revolutionize healthcare education. It is AI is revolutionizing healthcare education. So the way that our medical students, dental students, et cetera, are learning is so different than the way uh, I learned, which was with a textbook and a lecture series in the 1890s. So, which is a good segue, Susan, to this slide. So this is a famous painting from the 1890s entitled The Doctor. And this is the way doctors were thought of uh, up until recently. And on the next slide, I'll show you what they might be thought of now. Yeah. So, how many of you have had this experience? You go to the doctor and you see the back of his or her head because they're looking at the computer screen. So, AI cannot replace the humanistic aspects of medicine. It can enhance problem solving, diagnostic capabilities, but the ability to empathize with patients and consider their psychosocial needs is something that cannot be fully replicated by machines. And this is one thing we really try and do in our division as we're teaching medical students and residents and rheumatology fellows. This is sort of you teach by example. You see the way that hopefully they see the way that we interact with our patients and it carries forward. But it's a big challenge. But I think I saw a statistic not too long ago that the average time a patient spends with a doctor for regular visit is 18 minutes. So think about that if you have scleroderma. It's just not tenable. So you may, one way that AI might help this is by a new term I recently learned of called ambient documentation. So the doctor walks into the room, asks your permission to document using AI, speaks with you, takes a history, might hear about how your dog and cat are doing or your grandchild's doing, and they do a physical exam and they talk about what your blood pressure is and what your lung sounds like. They walk out of the room and the note is written. Now, if that allows him to spend face-to-face time with you, then that's a good use of augmented intelligence. But then you'll see at the bottom of your note a disclaimer like this, because errors do occur. But I do think that this aspect may allow us to spend more time with people and less time with documentation. But AI also is going to be machine learning is going to play a big role in other aspects of medicine than documentation. So I happen to think that two fields that are going to feel this first will be radiology and pathology, because machines can read CAT scans, MRIs, X-rays, mammograms faster and better than people. So there'll probably not be as much of a need for as many radiologists and pathologists in the future. But in other areas too, endoscopy, genomics, et cetera. And then AI is a really big aspect of the pharmaceutical field these days. So you can use AI to discover and develop new drugs, new targets, look for potential drug interactions, predict biomarkers, a host of ways in which AI is going to change the way that drugs are developed. And hopefully the net result of that is going to be a shorter time between discovery and actually having those drugs available for our patients. So this just came out. This is an editorial in a journal that I subscribe to called Pharos, which is a journal of the Alpha Omega Alpha Medical Honorary Society. And I lifted the illustration because I think it's such a good illustration. But it says, AI will change how we deliver care, but it must never change why we care. Human touch is something we must not leave behind. It is the center of all that medicine is and everything it must continue to be. So we're not going to get away from AI, but we cannot get away from the humanistic aspects of what we do. All right, hot topic number 2, new drugs. So there's a new drug for pulmonary fibrosis, nerandomilast. Jascayd. Anybody heard of this drug yet? So this is the newest drug for pulmonary fibrosis. It's FDA approved for idiopathic pulmonary fibrosis, and it's FDA approved for progressive pulmonary fibrosis, some of which may include scleroderma patients. And the company, Boehringer Ingelheim, is very interested in doing a clinical trial in people with scleroderma, with or without lung disease, because they feel that this drug may actually have an effect other than slowing the decline in lung function. It may have effects on the skin or other organs. So keep your eyes open for that. And then sotatercept or Winrevair was approved, FDA approved for pulmonary arterial hypertension about a year and a half, maybe 2 years ago at the most. And this drug is, we're still learning more about it as it gets wider use, but has had a dramatic improvement in exercise capacity in people with pulmonary hypertension. Even in the clinical trials, it was used in people who were already on what's called triple therapy. So they're already receiving 3 different drugs to manage their pulmonary hypertension. And then when they were given this drug on top of that, they had a dramatic improvement in exercise capacity. So since about 25% of patients with pulmonary arterial hypertension have scleroderma, this is a big win for our patients. And what's coming next are drugs for Sjogren's disease. So we've never had any drug that was treating the underlying disease process of Sjogren's disease. And as you know, many people with scleroderma have secondary Sjogren's disease. And so we have drugs that may improve salivary flow. We heard earlier about other things you can do to improve your oral health. But these 3 drugs actually are targeted to the underlying disease process. And the FDA has given at least 2, maybe all 3 of these drugs what's called breakthrough status. So breakthrough status means, there's a real need, unmet need in this particular field, and it streamlines the amount of clinical trials that have to be done before they can go and seek FDA approval. But I believe that probably within this calendar year, one of these drugs will be approved for people with Sjogren's disease. And that's, at least in the early clinical trials, not only improves tear production, salivary flow, but also improves fatigue, which is a big part of Sjogren's disease. And then if you go to clinicaltrials.gov on the internet and you search for ongoing clinical trials in scleroderma and limit it to the US, these are the trials that I could find. So on your left, with the asterisk, are 3 drugs that are already FDA approved for the management of lupus. And then as I implied earlier, there are a lot of genetic similarities, genetic susceptibility similarities between lupus and scleroderma, autoantibody production. So anifrolumab is Safnella, approved for lupus. Belimumab is Benlysta, approved for lupus. And then a study looking at belimumab, which has been Benlysta, in conjunction with Rituxan. So pharma always wants to expand their market. And so it's good for us that they're interested in scleroderma because one of these may prove to be effective. And then on the right are a group of other drugs that are currently in phase 2 or phase 3 clinical trials. One of them with the little cross there, efgartigimod, that's already approved for myasthenia gravis and is now being tested in scleroderma. And then baricitinib, which is in a different class of drugs called JAK inhibitors, already approved for rheumatoid arthritis and a number of other diseases, is now also being looked at in scleroderma. And then the bottom two is, Miranda, you still here? Yeah, these are your drugs. So we're doing clinical trials at MUSC, the A-tier trial and the Conquest trial. So again, if you have diffuse scleroderma or even limited, but it's less than 5 years of disease duration, and you may have some interstitial lung disease, you might be a candidate for one of these clinical trials. All right, and then the last hot topic is CAR T-cell therapy. Who's heard of CAR T-cells? Can you explain it? No, okay. Well, all right, so there's the CAR, and this is the T-cell. All right, so we're going to break this down. This is CAR T-cell therapy for a rheumatologist because this treatment modality was developed in the oncology world. So CAR stands for chimeric antigen receptor. T is T lymphocytes, a particular type of white blood cell. And so CAR T cells are T cells that have been genetically programmed to recognize and to kill cancer cells. Okay, so put a line through cancer cells and put in autoimmune cells. So this is a type of treating cancer that is now being looked at to treat various autoimmune diseases. And this was from a editorial in the journal Nature from several years ago, illustrating, here's the CAR, there's the T cell, the race to develop this technology to treat cancer. And I can tell you that it seems to be just as much of a race in treating autoimmune diseases as it has been to treat cancers. This is how new this is. So January 2026, a review article, CAR T-cell therapy and systemic sclerosis, the next frontier in immune modulation. This is a way to provide sort of a living treatment. So these cells, once they're given to you, they divide, they stay around, and it's a living form of treatment with the potential, and that's in quotes, potential for putting the disease in remission where you don't require any other medications, or at least any other immunosuppression. So a lot of interest in this, a lot of early clinical trials, many of them being done overseas, but still some being done in the United States, including one that we hope to participate in, right, Miranda? In May or June, we hope to start this. So how does it work? So over here, step one, blood is taken from your arm. The T cells are separated. The T cells are sent to a lab where they are genetically modified so that a chimeric antigen receptor or the gene for that is placed in the cell. Then when those cells divide, they express on their surface that chimeric antigen receptor, the CAR, and they are grown up in the lab. Millions of cells are then grown up and then given back to you after some conditioning treatment. And then they are programmed to seek out the cancer cell and kill it. Or in the autoimmune world, to seek out the B lymphocytes that are making those autoantibodies that are driving the disease, whether it's lupus, whether it's rheumatoid arthritis, whether it's scleroderma. So I've been playing around with AI. And so I went to ChatGPT and I said, give me a cartoon that illustrates CAR T cell therapy for patients with scleroderma. And in about 60 seconds, this cartoon came out. So here's the patient with scleroderma. I don't think those are contractures, but they could be. The T cells are collected. They're sent to a lab, genetically modified into these supercharged CAR T cells. Then you get them back and zap. They attack your fibrosis and reduce the inflammation and fibrosis in the skin or the lung or wherever it is. So that's an AI cartoon of how these might work. Now, this is a very expensive, as you can imagine, very expensive treatment, but over time will be less expensive. It also requires your cells being separated and then sent to a lab where they're genetically modified. So it may take weeks for those cells to then be shipped back to your clinic and then reinfused. So there's another way of doing this, which is to use not T cells, not T lymphocytes, but cells that are called NK cells, natural killer cells that we all have. And NK cells can be given from one person to another. They don't have to be genetically matched. And so you can have these NK cells that are already programmed to seek out those autoantibody producing cells. And in other words, it's an off-the-shelf type of treatment. You don't have to wait weeks for your own cells to be modified and to come back. You thaw them and you give them. And that's what this trial that Miranda and I are going to do and Deanna Baker Frost are going to do involves those NK allogeneic cells. All right, so this is also very new. So this is from the New England Journal of Medicine, one of the top medical journals, just from 2024. CAR T cell therapy and autoimmune disease, a case series with follow-up. So these were patients who had lupus or polydermatomyositis, and there were some patients with scleroderma in this clinical trial. And so I pulled out some of the scleroderma-related data. And in your bottom left, these white dots are the level of autoantibodies. So we talked about SCL70 and centromere and RNA polymerase 3. So these were their autoantibody levels before in the open dots and after in the dark dots after the CAR T cell therapy. So you can see that the levels come down or even are undetectable. So in other words, the CAR T cells have found the cells that are producing the autoantibodies, they've eliminated them. Now, I find this a little bit humorous. So, and now remember, this is one of the top journals in the world. So they're looking at the effect of CAR T cell therapy in scleroderma patients, and they're looking at something called the activity index. This is not artificial intelligence. This is activity index score. And you see it comes down. And this is the skin score. that Dr. Baker Frost talked about. It came down. But there are two things that I would want to point out is the total number of patients is 4. And this is what really gets me. The title is Long-Term Outcomes in Patients with Scleroderma, 6 months. So, but it gives you an idea that how excited people are about this therapy, and but that we need long-term, we need larger numbers of patients. So that's why we need to do these clinical trials, and we need follow-up, not just for 6 months, but for 12 months, 24 months, even longer. So, and this is a little advertisement for that trial. So if you have interest in this, look it up on clinicaltrials.gov. Talk to Miranda, and we hope Deanna's going to be the lead site investigator here at MUSC. I'm going to help her on that, of course. And we hope to be very active in this clinical trial. So the next thing I did was I went to ChatGPT and I said, I'm trying to stay current. Yeah, I told a joke last night that has to do with trying to stay current. Somebody was in their kitchen with their kid, and they pulled out a bottle of dressing, Paul Newman's own. And the kid said, "Well, who's Paul Newman?" And the mom said, "Oh, well, he was this great actor, very handsome, sort of like was a senior moment, sort of like I'm forgetting who it was. Brad Pitt. Who said that? Excellent. So who is Brad Pitt? So the kid says, "Who's Brad Pitt?" So anyway, I'm trying to stay current. So I said, create a slide illustrating scleroderma care and research at the Medical University of South Carolina. 60 seconds later, here we are.
Oh, wow.
Patient care, that sort of looks like MUSC. There's the Cooper River Bridge. We're doing clinical trials, developing new therapies. We got a support group, expert team. Sort of looks like me, but not exactly. I had to play around with it for the next slide. Guy got the red glasses. All right. Any questions, comments?